Hi, this is Dr. Mehta from New York, reporting for ACR 2020. I wanted to talk about a very important topic, gout and comorbidities. There's a lot of talk at ACR about it, and wanted to highlight 5 particular abstracts at ACR. So, as we all know, gout is a very prevalent disease, very prevalent amongst older men, um, and there's a lot of comorbidities associated with this older age group. So abstract number 657 is the first one that I wanted to highlight. This is looking at a large scale data set all over US, the NIS, from the year 2013. They scanned 36 million patient charts to look for patients who've had heart failure as well as gout. And um, they were just trying to see what comorbidities are associated with gout, and heart failure seems to be the highlight here. This could be acute or chronic heart failure in patients who are diagnosed with gout. And what they found is just in the year 2017, 350,000 patients with gout were admitted to hospital, either for gout or heart failure. So they had comorbidities of gout and heart failure, and they were getting into inpatient hospitalization stays. Thus, I think heart failure is something important to counsel our patients about. Um, the next abstract that is looking at something even more important is cause-specific mortality, which is increased in gout patients. So this is a data set of veterans all over the US, and they did a matched study of 500,000 gout patients with 5 million non-gout patients. And what they found is specifically the comorbidity of gout increases the cause-specific mortality or death by 10% in these patients. Again, so it's important to recognize this and counsel our patients appropriately about it. The next abstract I want to talk about is abstract number 673, which is highlighting one of the complications that we always think about, but um, hopefully never have to um, deal with it at a regular basis. So this is amputation. Um, so as we know, a lot of patients who are diabetic have higher risk of amputation. So what the investigators did was looked at a large scale data set of 190 million patients. And what they found is of those patients who had diabetes, the risk of amputation was 13 times higher than those who did not have diabetes. However, it is important to note that even patients with gout had a 4.6 times higher risk of amputation compared to those who did not have gout. Again, as they analyzed a little more, they found that those patients who had gout and diabetes both together had a 22 times higher risk of amputation. Um, and thus, it's important to counsel, again, patients who have multimorbidities with gout about the potential risks, and then hopefully get the compliance level higher for gout medications. Um, the next abstract I want to talk about is abstract 681, which is highlighting low back pain and gout. So this is a study where they took 61 patients, some with 25 controls and a few tophaceous gout and a few non-tophaceous gout patients, and they did the dual energy CT scan, which is a CT scan specifically looking at gout on the in the lumbar spine. And what they found is that gout and serum urate level were associated with lumbar spine urate deposition. And the interesting part is that um, the lumbar spine urate deposition was present even in patients who had non-tophaceous gout. Um, and a lot of these patients had much more incidence of low back pain that they complained of according to standard patient reported outcomes measures. So thus, All of these studies are just highlighting what we need to counsel our patients about, and what are the potential risks and how much are the risks quantified. Um, and the last abstract I want to talk about is abstract number 651, where they looked at gout readmissions and quality of care in a single center study. And over time, what they found is that we as physicians are not doing a great job in terms of counseling patients with gout or giving them adequate medications during discharge, either from the hospital or from the emergency room. And thus, these are the patients coming back and getting readmitted. So overall, I think my take is that, we as the medical community, as physicians, as rheumatologists, need to look into um gout a little more carefully, counsel our patients adequately. And when the patients are admitted, when they're in your clinics, when they are in the emergency room, start adequate gout prophylaxis medications so that we can catch these patients in the system and prevent multimorbidity and mortality. Thank you so much for listening. You can tune in for more updates and follow me on Twitter at Bella_Mehta. Thank you.